All right, so welcome back. We're still chatting here in chapter 18 about treatment of psychological disorders. We're going to spend a little time talking about some biological and pharmacological treatments. So when we're talking about kind of biomedical therapies, these are therapies that reduce psychological disorders by influencing the central nervous system. Now, this process largely involves medication, but it can also involve different brain interventions, including electroconvulsive therapy, transcranial magnetic stimulation, and psychosurgery. Now, an appropriate balance of neurotransmitters in the brain is necessary for overall mental health. Psychological disorders will result if there is a chemical imbalance. Now, keep in mind, though, that this is one condition that's needed in order for there to be a psychological disorder. Now, medication that's used often influences the production and the reuptake of neurotransmitters within the central nervous system. So, although these meds don't cure a disorder, drug therapies are still very useful therapeutic approaches, especially when you combine them with therapy. So, the way that I sometimes explain it to clients is that the medication helps to take the edge off a little bit. So, it allows a person to begin to deal with some of the challenges that they face. Now, one of the most common disorders that's treated through medication is ADHD. So, attention deficit hyperactivity disorder, or ADHD, is frequently treated with medication. And the most commonly prescribed class of drugs for ADHD are what's called psychostimulants. While these drugs manage the symptoms of ADHD, the problem is that the effects of these drugs wear off very quickly, and it can be very difficult to find the correct drug and dosage, especially because you're giving ADHD meds to kids when they're very young, at a time when they're developing very quickly. And so it's very easy for that the relationship between kind of dose and correct drug to always kind of be interfered with as a child is developing as well. Now, another class of medications are what's used for antidepressants, and so these are drugs that are designed to improve moods. You tend to use it mostly for depression, but you can also use it for anxiety, for other phobias, and especially for OCD as well. And so antidepressants work by influencing the production and the reuptake of neurotransmitters that relate to emotion. So specifically, serotonin, norepinephrine, and dopamine. As the amount of neurotransmitters in the central nervous system is increased, a person's mood is altered. Now, the original antidepressants were tricyclic antidepressants and monoamine oxidase inhibitors, or MAOIs. And these also work again to increase serotonin, norepinephrine, and dopamine. However, both tricyclics and MAOIs often have very severe side effect profiles and some very severe interactions with other, common foods and things that we tend to take in. So the types of medications that are predominantly prescribed today are what we call selective serotonin reuptake inhibitors, or SSRIs. And how they work is they block the reuptake of serotonin, which leaves more in between the synaptic spaces between neurons, and so they continue to act then on the receiving neuron instead of being taken back up by the sending neuron. And one of the awesome things about SSRIs is they're safer and they have fewer side effects, even though they do have their own sets of side effects. SSRIs and other antidepressants are not effective, though, for disorders like bipolar disorder, because this disorder includes overly positive moods, and so there's already high levels of serotonin that are activated during those times. So treatment for bipolar disorder involves a combination of antipsychotics and antidepressants along with mood stabilizers. So one of the most commonly used mood stabilizers is lithium, and that is very helpful for treating these manic periods, the periods when you are overly, when you're kind of above happy, I guess. We also have anxiolytics, or anti-anxiety medications, and these are drugs that help to relieve fear or anxiety. And how they do that is they work by increasing the neurotransmitter GABA. Now, GABA is the most common inhibitory neurotransmitter within the brain. And so what it does then is it inhibits the action of the sympathetic nervous system of the autonomic nervous system and helps to kind of create a very calming experience. And the most common class of anti-anxiety medications are tranquilizers, and they're known as benzodiazepines. And the wonderful thing about benzos are they act within minutes, but they are incredibly addictive, and they can often have very, very major side effects. And so anxiolytic medication is very carefully monitored, and oftentimes before being prescribed an anxiolytic, you'll be prescribed an antidepressant. And also it's important because anxiolytics already increase GABA, which is an inhibitory neurotransmitter. If you mix it with alcohol, you can have severe um, very dangerous side effects, up to and including death. So not a good idea to mix this drug with alcohol. We also have other medications called neuroleptics, or the antipsychotic drugs, and these treat symptoms of schizophrenia and other psychotic disorders. And so some of them will treat positive symptoms, some will treat positive, negative, and cognitive symptoms, so you kind of get a little bit of a mix. Now, antipsychotics in general reduce the positive symptoms in schizophrenia by reducing the transmission of dopamine, and they improve negative symptoms by influencing levels of serotonin. So bring down the dopamine, bring up the serotonin. So, the first kind of antipsychotic, or the first neuroleptic, known as chlorpromazine, has been noted to be the single greatest advance in psychiatric care. It really allowed for treatment for people who prior to this did not have a treatment. However, like all medications, long-term use can cause permanent neurological damage. And in this particular case, and particularly for people who have been diagnosed with schizophrenia, they're at a much higher risk of developing something called tardive dyskinesia, which is uncontrollable muscle movements, and usually in the mouth area. And so this is one of the side effects of using this medication long-term. So this is just a little bit of a chart for you. It kind of tells you about the type of drug, common names for them, what they're used for, and then some of the side effects. And it's important to note here that there are every drug has side effects, right? And so oftentimes the challenge is finding the right psychiatric drug to actually meet the challenge that you have. And often this is a bit of a it's not a one-shot kind of thing. It's something that takes a lot of time to, and close work with your psychiatrist or family doc to actually find the right combination and dose and frequency and all of that stuff. So now, it's important to note that with medications there are some important problems. And firstly, one of the problems that we need to kind of consider is the response rate and the placebo effect. So here's the thing. Only about half of patients on antidepressants respond to medication. And of those, we know that about only 40% are actually responding to the effects of the drug, which would mean that of the half that are responding, 60% of them are actually responding to placebo and not necessarily to the medication that they're on. The other challenge here is that idea of finding the therapeutic window. And so when we're talking about the therapeutic window, we're talking about that that sweet spot of having the right dose and the right medication that's actually going to affect and improve symptoms. So this is one of those challenges that that is very common for any psychiatric medication. Now, in saying that there are problems with medication, I am not discounting the use of medication. In fact, I'm a big fan of the use of medication when it's used appropriately. But it's important to note that these are some of the challenges that need to be considered when we're using pharmacological interventions for clients. Another kind of problem is this issue of symptoms and not causes. So for example, for some disorders, medication doesn't actually treat the cognitive components that maintain the disorder. So for example, in both depression and in anxiety, we can treat it with medication. But the problem is we're not actually treating some of the underlying cognitive factors that maintain the disorder. So specifically, and especially in depression, we do know that there are particular cognitive styles that actually help to maintain the depression. So rumination of things, continuing to buy into certain automatic beliefs or automatic negative thoughts, or using unhelpful thinking styles. All of these things actually help to maintain depression. And it doesn't matter how much medication you take, you're not then going to be treating the actual things that are maintaining the disorder. And so we have to keep that in mind when we're talking about medication, is that the medication may help to take the edge off a little bit, or maybe helpful to kind of boost your mood. But there is this other component that we still need to treat the cognitive processes that are contributing to the disorder. So even for what we kind of call biological mental disorders, ones that are very strongly biologically based, behavioral therapy tends to improve outcomes. And so, the medication is in and of itself is not sufficient to treat every disorder. And so you do need this combination between medication as well as psychotherapy. Other important concerns about medication are concerns surrounding safety. Now, the thing is that we have to keep in mind that most medication trials are conducted on adults, but medication then is also prescribed to children, despite not having had the same types of medication trials. Okay, and under this is the assumption, and this really is an assumption in many areas of life, that kids are just little adults, and we know that that's not the case. The um, biological systems, the body-based systems of children are very, very different from that of adults. And so it's important to note. There was a very recent study that demonstrated increased unexpected deaths among children and adolescents on antipsychotics. And so the study particularly looks at kids who were in care. And so it is very important to note that at a statistical level, for some medications, there are significant concerns about safety, and as consumers of both medication as well as, hopefully in the future in your professions as advocates for your patients, it's important to understand that these are important considerations and need to be taken seriously. Another big concern here for many people is the medicalization of reactions. So when I say that, what I'm meaning is that there is evidence that there's a pharmaceutically driven agenda that's built into the DSM. I mean, we do know that that we have increased reliance upon medication, even for times where medication may not be the frontline treatment. So, for example, for young children, the frontline treatment, the best intervention for a child with ADHD at face value, at first step, are behavioral treatments. And so if we look then and say, well, if behavioral treatments are actually the frontline treatment, why are we then focusing on prescribing medication prior to that? That's an important question to ask, and it is something that really does need to be considered. We also need to note that with some drugs, there's a high discontinuation rate. So the reality is, like I said before, most drugs have side effects. That's an important thing for us to recognize. But because of that, many people discontinue medication. The problem, though, is that with this high discontinuation rate, doing so increases the risk of relapse due to treating symptoms instead of causes. The other issue that we know with medication is that it can lead to high levels of dependence on other drugs as well. We know that there's a rising trend in the use of long-term use for antidepressants. And it's important to note that antidepressants were originally designed for short-term use. It also appears that the withdrawal side effects keep some people taking medication longer than what is needed. So the fear of the withdrawal, the discomfort that the withdrawal causes some people to continue to take medication longer than what is actually needed, and longer probably than what it's called for. Finally, there is another concern surrounding unknown long-term risks. I mean, look, we're dealing here with the first, maybe really the first generation of people that are using medication for long periods of time. I mean, we are now only beginning to have kids who are adults and who were diagnosed in the 90s with ADHD and began psychostimulant treatment then. So, I mean, we don't really have long-term outcomes for some of these things. And that's an important consideration when we're asking people to take medication for the long haul. So here's the realities. There's no studies that have been conducted to determine what the long-term effect is of taking any medication, right? Though we do know that with taking medication, there are physiological changes that happen to the body. So for example, there was recently a very important lawsuit against Johnson and Johnson surrounding some of their medication that they have sold because of the fact that males have developed breasts because of long-term medication use. All right, so why am I telling you these kind of things? Well, I'm not telling you this to scare you, but again, this whole thing that we need to consider how we're using medication. We need to consider the tools and if whether all of these tools and which one of these tools is necessary when treating a psychological disorder. One of the trends that is quite concerning is the use off-label uses for medications. So, for example, off-label is when you would use a drug to begin to treat something else other than what it was initially designed for. So, and this happens quite often because what happens is when people begin to take a drug, we begin to say, "Oh, I bet you it probably worked for this," and what do you know? It seems to, and so people begin to use it for that. The problem is, though, that sometimes we can develop off-label uses that may not actually be in the best interest of clients. For example, using antidepressants to treat social phobias. This hasn't really been tested, and so while this may improve some symptoms, is that really the best use of the medication? What about this? Recently Prozac was rebranded as a product, called Serafem, which is for premenstrual dysphoric disorder. Okay, basically, it's something that's to be used by women when they are going through PMS. So here's the challenge: is an antidepressant necessary for a woman who's undergoing PMS? What about using antipsychotics to treat non-psychotic conditions such as what's been labeled impulsive aggression? I mean, there's a rising trend in giving antipsychotics to young children, and this is a concerning thing for many adults, and I think it should be, because we are using, this is an untested off-label use for medication. There's also been a trend of prescribing stimulants, ADHD medication, to children who are 2 or 3 years old. I mean, that is, in my opinion, quite extreme. And if that's the case, and if that's really needed, should only be reserved for the most extreme of cases. So, what's my verdict here? Look, medication is valuable when it's used correctly. However, like I've said before, the best treatment is the one that works best. And in many cases, medication is not the best treatment for certain psychiatric or psychological disorders. And it is important for us to consider the fact that there are other treatments that are more efficacious. The problem, I think, is one of convenience. Taking a pill is easy. Doing the hard work of therapy is not. And I think that's part of the reality and the challenge that mental health professionals face in this day and age is this dichotomy, this problem here. Now, as a very important aside, if you or someone you know is considering coming off of psychiatric medications, please, please, please do your research. And when I'm saying that, this would include, please speak with your doctor or your psychiatrist about your intention to do so. Talk to your loved ones about your decision and the potential side effects that they should be looking out for. So in case you are busy coming off stuff and you're not recognizing some of the things that are going on for you. And the other important thing is to do your research about withdrawal side effects and how to safely taper down your use. So for example, there's a group called the Withdrawal Project that talks about how to use this medication. And it's really important to remember as well, for some people, staying on medication is something you should probably consider doing, particularly if you have a disorder that really tends to benefit a lot from proper medication management. So please don't. Psychiatric medications are never things you should just play around with and kind of try to hack or do on your own. Please do talk to the people in your lives who are experts in these domains and who can really be of help for you. So, kind of getting off my soapbox for a bit and switching gears here, let's talk a little bit about some direct brain interventions. So, for some severe disorders, it can be best to directly influence brain activity via electrical activation of the brain or through brain surgery. So, one of the therapies that is used is electroconvulsive therapy, or ECT. And that's when you deliberately pass electric currents through the brain, and what it does is it basically triggers a brief seizure. Now, ECT has been used since the 1930s to treat severe depression. Now, ECT also has a very kind of sordid history because I think they maybe took things a little bit too far. And when I say they maybe did, I mean they did. Now, today, ECT is only used in the most severe cases when all other treatments have failed. And the practice is significantly more humane than what it was in the past. So, I mean, here's kind of a little bit of a picture of what happens, how it all kind of looks, and how, how the whole kind of thing flows through. Now, here's the thing. ECT is actually very, very effective. About 80% of people who undergo 3 sessions of ECT report dramatic relief from depression, particularly for people who have intractable depression that has not responded to medication, has not responded to therapy. This can be a lifesaver for some people. One of the challenging things, though, is that these positive effects often don't last. So about over half of patients experience relapse within 1 year. So that means then that people have to keep coming back over and over for ECT. The other significant downer is that ECT may also cause short-term memory loss or some cognitive impairments. So again, you really have to balance out the pros and the cons, the risks and the benefits of seeking out this particular treatment. There's another newer method called transcranial magnetic stimulation, or TMS, and what it does is it uses a pulsing magnetic coil to electrically stimulate the brain. And it is a very, very cool thing to kind of watch. Now, the issue here with TMS is that, well, I guess some of the benefits are that, first of all, you don't need any sedation to do this to someone. There's no seizures, no memory loss, and it might be just as effective as ECT. It's also been used to treat Parkinson's and schizophrenia, but at this moment in time, it's not a very well kind of situation. They need to do a lot more work to make it actually have the benefits that they're claiming it does. So basically, there you go. That's what TMS. You kind of put someone's brain in a spot. You use this kind of big coil thing. It stimulates a brain region, and what it does then is it activates some neurons. So there's a great link here below too that you can watch and take a look at some how TMS actually looks in the real world. Now finally, the most severe biological intervention that we can have is what we call psychosurgery. And that's when we are purposefully removing or destroying brain tissue in the hope of improving a disorder. It is reserved for the most severe cases. Now, the most well-known psychosurgery is the prefrontal lobotomy. Now, straight up, there are very few centers in the world that still conduct psychosurgery today. It is a thing that we just really don't do anymore, because we know now that chopping around in people's brains is a terrible, terrible idea. So now usually what happens is that if a surgery is performed, they're significantly more limited in nature, and they're called a cingulotomy. And so that's when you are usually removing a portion of the anterior cingulate gyrus bilaterally, so on both sides of the brain. This is used for the treatment of chronic pain and for treatment-resistant OCD. Now, again, your OCD would have to be real, real bad for us to consider this as an option. Honestly, to let you know the truth, I don't know of a center that actually does psychosurgery, though that is likely more of a question for a psychiatrist. But anyways, it is a very, very rare thing. I don't know anyone who has gone for one. I've never asked the doc to consider this for a client, but there you go. So yeah, it is still something that happens, but in an extremely limited fashion. All right, I'm going to pause here, and we'll talk about social interventions in a bit.